Good morning. My name is Lance Christian, and I'm the Executive Director of the ALS Association, Oregon and Southwest Washington chapter. I want to welcome everyone to our first session for our 2021 Research Week. We're excited to have a panel of presenters across today and the next 3 days on exciting information about progress for ALS research and research that benefits the quality of life of people with ALS. We're a proud supporter of basic science research through the National ALS Association, but we also are actively always engaged in supporting research into quality of life for people with ALS. These sessions are made possible by our generous sponsors that we want to take a moment to thank: Mitsubishi Tanabe Pharma America, the Providence Brain and Spine Institute, Pharma, and New Motion. Their support has made these events possible, so we want to say thank you to them. Today, our sessions are very exciting. A few housekeeping items. There will be an opportunity at the end of today's research session for question and answers. Please type in your questions into the Q&A box. All participants and video and microphones are disabled to reduce interruptions. And today's presentation will be recorded for later viewing and will be available on YouTube as well. We can email it to people. We're scheduled for 1 hour today, and we will work very closely to stick to that time frame. I'm very excited to have two presenters talking about important topics that are near and dear to our heart today. We're happy to have Bets Peters, a speech language pathologist, and Melanie Fried-Oken, PhD, to present on brain-computer interface. ALS research can come in many different arenas that can be about basic science, but also can be about applied tools that support people living with ALS, like assistive technology. And the area of work that Bets and Melanie both specialize in has a very important role in making sure people with ALS have the ability to navigate their world and direct their own lives. Bets is a researcher and speech language pathologist at OHSU. She's a PhD candidate at Portland State University and is on staff at OHSU Neurology and Neurosurgery departments. We've known Bets for years, as she also was an assistive technology professional with our own chapter early in her career. Melanie Fried-Oken is an amazing and well-known professor of neurology and biomedical engineering and otolaryngology at Oregon Health Sciences University. She is one of the pioneers in AAC and communication for people living with ALS, going back many, many years into practice. She's an amazing researcher, and she is consistently brought forward research projects that have advanced the knowledge of assistive technology to allow people with ALS to communicate. So we're pleased to have them present today on brain-computer interface technology. And we want to move forward, and I want to bring forward Bets to present initially on some of her research activities.
Okay, hi everybody. Let me share my screen here. Thank you, Lance, for the introduction. As Lance mentioned, I used to work for the ALS Association, and I've been working with people with ALS clinically and in research for about 13 years now. So it's an area that I'm very passionate about. I focus in assistive technology, so technology for communication, as well as for computer access and telephone access. And it felt like a natural progression from moving from the ALS Association to doing the research I'm doing with Melanie at Oregon Health and Science University. So I'm going to talk a little bit about what augmentative and alternative communication is, just really briefly, and then talk about some basics about brain-computer interface and how it can be used for communication. Then Melanie's going to take over. She'll talk about some of the specific research that we're doing in our lab. And then at the end, I'm going to talk about some of the research that I've been doing recently for my dissertation at Portland State. So, there we go. Okay, so brain-computer interfaces, here we go. So many of you may be familiar with augmentative and alternative communication. So these are methods that help people communicate when they have some difficulty communicating using natural speech. It can be anything ranging from computerized systems or smartphone-based systems where you can type in words and have them spoken aloud by the computer, to low-tech things like writing on a tablet or pointing to words on a communication device or a communication board. And an important component of being able to use augmentative and alternative communication is an access method. So how do you actually interact with either the device or a printed board physically? So if you have the use of your hands, you have a lot of options for access. You can use the touch screen on a tablet or a smartphone. You can use the mouse and keyboard on your computer. If you have some reduced hand function, but still are able to use the joystick on your wheelchair, you can use that to control a computer or a speech generating device. If you're able to move your eyes accurately, you can use an eye tracking computer. You might be able to move your head or move your foot or maybe even waggle your eyebrow. Pretty much any movement that you can do reliably is something that through assistive technology you can use to control a computer and you can use for communication. Amanda or whoever the new assistive technology coordinator is at the ALS Association can give you more information about that, or whoever the speech pathologist is that you're working with can tell you more about communication devices and access methods. So these are all things you can do to access a computer, but they require movement of some part of your body. So what happens for folks who really aren't able to move anymore, or maybe are still able to move, but the movements are unreliable? Maybe you can move your chin or twitch your eyebrow, but if you get really tired or if you're on certain medication, that gets harder to do. What are some options for access in that case? So really you're left with your brain. Your brain still functions well, even if you're losing some muscle function. So how can we use the brain as a method of controlling a computer and a method of allowing you to communicate? That's where brain-computer interface comes in. So BCI is a way of controlling the computer without using any muscle activity. So it allows you to interact with the environment using only your brain signals. And it has a wide range of possible applications, including communication, which is what we focus on in our lab, but also just general computer access, controlling a power wheelchair, controlling a robotic arm, or controlling things in the environment like a TV or a door lock. These are things that are not really commercially available yet, or not really fundable through insurance. This is mostly still available just in a research context. There are a number of BCI research labs around the country, in addition to the work that we're doing here in Portland, but it is still not widely available yet. It's getting there, but it's a slow process. Okay, so there are two major types of BCI. One is implantable, which actually requires brain surgery to implant an electrode array basically onto the surface of the brain or possibly deeper in the brain, depending on what type of signals you're trying to collect. This has some advantages and disadvantages. Obviously, a disadvantage is you have to have brain surgery. It's a higher risk procedure, although they are improving that procedure. But it does allow you to get better and clearer information from the brain. If you want to learn more about implantable BCIs, definitely tune in to the session on Wednesday. Dr. Nishal Shah is going to talk about some really exciting research with implantable BCIs being done by the BrainGate group. But our research at OHSU focuses on non-invasive BCI, and that's what we're going to talk about today. Here you see my dad wearing the electrode cap during a testing session at OHSU. We use non-invasive methods where we're collecting the brain signals from the surface of the scalp. So no surgery required, just a temporary wearing a cap or an electrode headset to gather the signals. And I'll talk a little bit more about how that works. But first I want to clarify something. So if you've seen stories about BCI in the news or maybe on 60 Minutes or something like that, sometimes you'll hear BCI described as mind-reading technology. And I want to be very clear that that is not what it is. The popular misconception is that you can just think something and the BCI knows what you're thinking and will say that out loud. And, obviously that presents concerns about privacy. You don't want everyone to know every little thought that you're having and have that spread out into the world without your control. But that is not what BCI does. I want to be very clear about that. It really works more like any other computer access method. You are making a conscious decision in your brain to say something, a specific thing, and you send signals to a computer that then will produce that message, either write it on the screen or maybe produce it with synthesized speech from a speaker. But you have control over what is being said and what messages are going to the computer. So just keep that in mind. It's not mind reading technology. So our non-invasive BCI uses electroencephalography, or EEG, which involves electrodes placed on the scalp. It records electrical activity in the brain cells, and it's the same type of EEG that's used for diagnostic tests for things like epilepsy or sleep disorders. The important thing for BCI is that it can pick up reactions to stimulation. And I'm going to talk about some examples of how it does that. There are many different types of brain signals that can be used for computer control and therefore to control communication software. I'm going to talk about 3 of the ones that are used most commonly. 2 of them are ones that we've used in our lab, and Melanie will talk more specifically about what we do with those later. So the first signal I'm going to describe is the P300 event-related potential. And that is a brain response to an infrequent or novel stimulus. So if you imagine that you're seeing a series of pictures, maybe they're flashing on the screen one by one, and you see potato, 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 parakeet. Well, the parakeet is something kind of new and different. It breaks the pattern. It's more interesting, more stimulating. You have an involuntary brain response when you see that parakeet, just a little spike in your brain signal that kind of says, ooh, that's new and different, or that's interesting. And it turns out we can actually pick that up using EEG, and a computer algorithm can tell the difference between that exciting novel stimulus like the parakeet versus the boring stimulus that you've seen over and over like the potato. It actually makes a pretty different looking brain signal, as you can see here. And we can use that for communication by having you focus on specific letters. So if you want to type the letter A, you would be focusing on the letter A as it's presented on the screen and ignoring all the rest of the letters in the alphabet. And so hopefully when the A is highlighted or flashed or in some way, shown, you would have that involuntary response to the A and get that P300. So that's how we can use that for typing. Another type of signal often used for BCI is called the steady state visual evoked potential, or SSVEP. That's a response to a flashing or oscillating visual stimulus. So something like a flashing light, or often people will use kind of a checkerboard on a computer screen, and the black and white alternate, so it kind of makes a flashing effect. This response is measured over the visual cortex. So basically, when you're seeing that flashing light, you have a response in the visual area of your brain that kind of matches the frequency of that flashing light. So for example, if you have 4 flashes or 6 flashes or 8 flashes that all occur in the space of 1 second, your brain has a response kind of in time with that. It's like clapping along to the beat of a song, where if the song is fast, obviously you're going to clap faster. If the song is slow, you would clap more slowly, kind of a similar idea. And again, we can use this for communication by associating those flashing lights, possibly in different areas of the screen, with different letters or words or groups of letters. So we might have the A being the slow flash, the B being the medium flash, the C being the fast flash. And depending on which flashing light you're looking at, your brain kind of responds in tune with that frequency, and the computer can tell which letter you're paying attention to and which letter you want to type. A third signal that's commonly used in BCIs, including communication BCIs, is motor imagery. So that's something like you would be instructed to imagine squeezing your hand, or imagine wiggling your toes, or imagine playing tennis, things like that. And researchers have actually found that imagining different movements, especially in different parts of your body, like your hands versus your feet, actually causes changes in the brain activity in different areas. So if we have a whole bunch of electrodes across the top of your brain, kind of ear to ear over the top of your head, that's where a lot of the motor function and motor imagery activity in your brain happens. And we can actually pick up different patterns of activity for different imagined movements. And so again, to use that for communication, you might do something like associating, imagining squeezing your hand with the word yes, and imagining wiggling your toes with the word no. Or for kind of a typing-based system, you might imagine squeezing your hand to cause a cursor to move across the screen, and you might imagine wiggling your toes to select the highlighted item. So that's just a quick explanation of some of the methods that are commonly used for non-invasive BCI control and for communication. And I'm going to pass it over to Melanie, who's going to talk about some of our research using those signals at OHSU. Melanie, are you ready to go?
I am. I'm going to share my screen. Let's see. I'm going to share sound. And we're on. Thanks for having us. I'd like to tell you about the research that's going on at OHSU in BCI. Our story started in 2011 when in my AAC clinic, I met 3 men who presented with major challenges in how to access their computers and communication devices. 2 men presented with brainstem strokes and 1 man presented with ALS. They didn't have a way to select letters or words from communication devices, and we needed to find another method for them to select. Also, their spouses and care providers said to us, I know he understands everything, but he doesn't have a way to tell us. And I wish there was a way that he could just use thoughts or his brain waves to select letters or words. And from that, we formed our OHSU BCI team. As Beth said, we use non-invasive EEG, and we have 5 teams of people who are working for us. This is a really complex problem or challenge. So the first team are engineers and computer scientists, and they show us signal acquisition and processing work. So how are they going to get those how are they going to collect those EEGs and that P300 that we need, and how are they going to process that? Then we have the neuroscience team. They transfer the signals from the machine to our end users. We have a natural language processing team. They use language databases to help the system know what letters or words are chosen, very similar to when you're texting or using Word and words are predicted for you. We have a clinical rehab team, and Betts leads our clinical rehab team. We work with community dwelling potential end users to determine what they need and to test the device developments for us. And finally, we have a technology implementation team, and they put it all together for assistive technology. We meet weekly. We've been funded since 2011 for this work. Our vision on our team is to make BCI available for independent use so that individuals with the most severe disabilities can return to their families to live in the community and contribute to decision-making and medical management. We have 2 strands of research. One is the system performance, where we ask, how can we maximize use of the computer and signals for communication? And the second area is user performance. How can we maximize end user experience and satisfaction given their needs and abilities? We base this on 3 design principles. The first principle is called participatory action research. You've heard people say nothing about us without us. Individuals with disabilities are included in every phase of our research. So that, a few years ago, was our very large team. Individuals with motor limitations are the experts. We learn from you and we take your guidance. We ask you for your feedback along the way as we're developing, and then we have an iterative process where we change things based on what you tell us. The second principle we use is called user-centered design. And from the International Standards Organization, this is defined as users of a proposed product influence how it takes shape. Your vision could be tomorrow's life-changing product. We have three groups of users for user-centered design. The first group are end users, people who actually use the product, so people with ALS or individuals with motor challenges. Our second group are those who may occasionally use the product or use it through an intermediary, so you family members and care providers. And the third group are those who will be affected by the use of the product and make decisions to help with the product. So that would be speech and language pathologists, your other therapists, and physicians. The third principle we use is called translational research. And here we're moving knowledge that's gained from basic science. And for us, the basic science are the brain waves, to its application in clinical and community settings. You might have heard it called bench to bedside or bedside to community. And there are 5 stages of translational research. So here's the same heuristic, and I'm going to talk about the different stages from the perspective of our BCI team. The first stage is engineers develop hardware and software to obtain and process brainwaves. The second stage is a multidisciplinary team designs a BCI for people with locked-in syndrome. Then we have translational clinical teams that iterate development of the BCI for typing, our group for typing, and then we test it with different participants. The fourth stage is we have clinical researchers who make BCI available to patients to use in their homes for communication. And that's as far as our team gets. We are not manufacturers. We don't provide products at the end stage to the community. We provide science and knowledge so that manufacturers and companies can take it further. So the fifth stage is adding BCI to the assistive technology marketplace internationally. So those are our goals and how we're considering design. Let's talk for a few minutes about our first big area, which is maximizing system performance, and that's the technology. We've developed a few different screens, a few different BCI spellers for people to use. The first one is called the RSVP keyboard. It stands for Rapid Serial Visual Presentation. And for this, we use that P300 response to a surprise letter that Bet's described. I have a short video that describes what we're doing.
This video demonstrates the RSVP Brain-Computer Interface System, or BCI, and how it can be used for communication by people with severe speech and physical impairments. Here you can see one of our study participants, Greg, wearing a cap that is fitted with electrodes. The electrodes are connected to a laptop computer. Letters are flashed quickly on the screen. When Greg sees the letter he wants, he will use a strategy to change his brain activity in order to select the letter. Possible strategies include thinking yes or bam when the target letter appears. After the sequence of letters has flashed on the screen, the system will identify the letter which caused the biggest spike in Greg's brain activity. Here you can see that the system has selected the letter A. The long line next to the A indicates strong brain activity for that letter. During calibration, Greg is given specific letters to look for. Once the system is calibrated, he can select his own letters and type anything he wishes. We hope you have enjoyed this demonstration of our brain-computer interface.
Okay, are you ready to type with your brainwave? I'm going to show you a letter. You'll see an A. Then you'll see a plus sign and letters going very quickly, rapid serial visual presentation. Look for the A in that series of letters. Here you go. Ah, did you see an A? Well, when you saw that A, you had a brain response, which is called the P300 wave, an event-related potential at about 300 milliseconds. That's how the system works. So you are actually selecting the letter with your brainwave. Now, what we did just now was you saw a letter and typed it. We can do the same thing for whole phrases. So I'm going to show you a phrase, go to the movies, and I want you to type the T in that phrase. So look for the T. Here you go. Ah, the computer said that you typed the T. Good job. So that's how brain-computer interface works with the RSVP keyboard. We've made another keyboard. It's called a shuffle speller. It uses a different brainwave. It uses the visual evoked response, or SSVEP, steady state visual evoked potential. And for this one, the letters appear in boxes, and next to each box, you can see lights. You see them? Now, each light is flickering at a slightly different frequency. And your brainwave sees the different frequencies, and we can tell by what letter you're looking at, which frequency box you're looking at. And that's how we select the letter. So I have a short video that describes how the shuffle speller is used with a different brainwave.
This video will review how to type words with your brainwaves using Shuffle Speller. During typing, you will see all 6 boxes on the screen at the same time. Letters will appear in the boxes, and you will select the letter you want by looking at the flashing lights. Letters will appear in this area. This is your keyboard. They include the letters of the alphabet as well as 2 symbols, the less than symbol for backspace and the underscore for space. This area displays the word you will copy. To select a letter, first find it in the middle of the screen. In this example, you would start by finding the letter A. The letters are in alphabetical order to make them easier to find. After a few seconds, each letter will move into one of the 6 boxes. The color of the letter tells you where it will go. In this example, the A is lavender, so it will move to the lavender box in the top right corner of the screen. The lights will start flashing. Look at the light closest to the box with your target letter. Here, you would look at the light next to the lavender box. Remember to look at the flashing light, not at the box itself. You need to look at the light in order to change your brain signals in a way the computer can recognize. Now the letters will move again. Keep your eyes on the A and watch as it changes color to show where it will go next. Sometimes your letter will stay in the same box. Watch the A as it moves to the next box, then look at the light closest to that box. You will follow your letter around the screen in this way until the computer makes a selection. Sometimes you will only need to select your letter once, but sometimes you will need to select it several times. In this example, the computer needed 2 selections to type the A. When a letter is typed, you will hear it spoken aloud. You will also see a change in the target word area. Correctly typed letters will appear in green, as the A does here. Once a letter has been typed, you can begin selecting the next letter. The next letter in this word is P, so you would find it in the center of the screen, and then follow it as it moves to a box. Watch as the next few letters are typed.
Well, that gives you an idea of how Shuffle Speller works. Already today, we've stimulated both your P300 and your SSVEP. Congratulations. That's all the time I have today to describe some of the technology performance research we're doing. I just want to spend a few minutes talking about the user performance research we're doing. In this area, we have addressed many different research questions, and many of them came straight from you, such as, what do end users, family members, and caregivers want from a BCI for communication? What's important to you? How can end users who can no longer speak provide us with valuable user feedback? And we've taught the BCI community how to use different eye gaze methods and other forms to provide feedback. What visual skills do end users bring to the BCI task? So we've done experiments where we've compared that Shuffle Speller, that RSVP keyboard, and then there is another P300 speller that looks like a grid. It's called the matrix speller, and we've compared different ways of typing with those systems based on visual skills. How can we assess end user skills for BCI performance? You unfortunately may meet some individuals, some clinicians who say, no, he or she doesn't have any skills because we can't assess them. So that's one of our strengths, is helping the BCI community from a clinical rehab perspective, identify how to best assess end user skills. And then finally, our current study is, should BCIs store personalized vocabulary in the device to help with typing speed? We also are showing a preview of letters before the RSVP keyboard to improve spelling accuracy and speed. Well, if you're interested in participating in our OHSU BCI research, here's some contact information. And I know Lance has all of our contact information, and this set of slides will be available, or you could look at our website. Our BCI research is part of a group. We're called the Consortium for Accessible Multimodal Brain-Body Interfaces, which is a mouthful, so we call ourselves CAN-B, and our funding comes from NIH. So now I'm going to pass it back over to Bets, who's going to talk about additional ALS research that is being performed. Thanks for listening.
Okay, thank you, Melanie. So as you can see, we've got some exciting research going on at OHSU. There's exciting research being done at many labs around the country and around the world related to BCI, and BCI kind of represents an exciting future direction for augmentative and alternative communication, offering a new means of communication for people who aren't well served by the technology that's already out there. So we've talked some about the future. I'm going to talk a little bit about the present. As Lance mentioned, I'm also a PhD candidate at Portland State University, and I'm going to talk a little bit about the research that I'm doing for my dissertation. So some of you actually may have been involved in this research. I conducted an online survey earlier this year, and you may have heard about it through the ALS Association or through the National ALS Registry. So if you filled out the survey, thank you very much for participating. I ended up getting 216 responses, so a pretty good set of data. The survey asked about a few different things related to communication. So first, it asked about the different methods of communication that people are using. So combination of speech, different AAC methods, high-tech methods, low-tech methods. Basically, what are you doing to communicate? That is something that we don't really have good current data on. The last major survey that was done about communication methods for people with ALS happened in the mid-2000s, so kind of before the advent of the smartphone, the tablet, all this technology that we use so frequently now and that many people with ALS use for communication. So I wanted to find out, what are people doing in 2021? What's the current state of communication for PALS? I wanted to learn about people's experiences getting treatment and services related to communication and AAC, and also about something called communicative participation, which I'll talk a little bit more about in a couple minutes. So one of the questions I asked was, what methods do you use for face-to-face communication? So if you're talking with somebody who's in the same room as you, how do you communicate with them? And people who filled out this survey came from kind of all different places in the progression of ALS and in the progression of changes in speech function. So we used a scale from the self-administered ALS FRS-R, asking about how's your speech function, essentially. And the responses ranged from 4, no change, easy for people to understand, 3, some noticeable speech change, but not having trouble yet with people understanding you, 2, sometimes you need to repeat something to help people understand, 1, you're combining speech with other communication methods, or 0, you're unable to speak at all. So current communication methods for people with no speech change. Unsurprisingly, 100% of those folks reported that they use speech for face-to-face communication. Some people also said that they use gestures and writing to support communication. A few people mentioned smartphone, tablet, or laptop or desktop computer. It's difficult to know whether those folks are actually using those devices for face-to-face communication or whether there was some confusion about the question. But that's what was reported here. For people who've experienced a little bit of speech change, but still have good speech intelligibility, again, everybody's still using speech. We see a little bit more use of gestures and a few mentions of other methods. If you're at the stage where you sometimes need to repeat yourself, so your intelligibility has reduced a little bit, again, everybody's still using speech. We see more use of gestures and starting to see some more use of other methods. And where things really start to change is here at level 1, where speech intelligibility has been really affected and you're starting to combine speech with other communication methods. We still see most folks are using speech, at least some of the time, for face-to-face communication. Almost everybody reported that gestures were an important communication method. So that's things like pointing at something, maybe a thumbs up or thumbs down for yes and no. It might be using eye movements to look at something or to give a yes/no response. And we see a lot more use of things like smartphones and tablets with communication software, or a purpose-built STD, something like a smart box or a Tobii Dynavox system, if you've seen those. As well as a lot more people using writing and some of these other methods down here. And for people who are unable to speak, only 1 person reported still using some speech at that level. Again, most people are still using gestures and finding that important, and we see a lot more use of other methods. So increased use of other methods has to do obviously with changes in speech function, but also potentially changes with physical function. Maybe you're not able to easily give a thumbs up and thumbs down for yes, no anymore. So you're starting to use some of these other methods. I also looked at access methods. So how are people controlling smartphones, tablets, computers, or purpose-built speech generating devices? Many people said that they still use standard access. So that's your touch screen on a touchscreen device or your standard mouse and keyboard. The next most common method was maybe I can't type on the keyboard anymore, but I can still use a mouse or a trackball to type on a virtual keyboard on the screen. Lots of people also used eye movement. That was the next most common method. A lot of people use voice access. So this access method includes all uses of the computer. So the people who use voice access probably aren't using their computers for communication, but they might be using voice access to write text messages or emails or things like that. Switch scanning was the next most common method. Few people reported they use head movement. A couple people said they use their foot to access the device, and one person said they use their nose. And the next topic I asked a lot about was communicative participation. So I'm just going to explain briefly what that is. All of these AAC methods that I've talked about should allow you to compose a message in some way, either to compose a written message or to point out words that your communication partner can see, or to compose a message that's spoken aloud by a computer. So that's great, but that's not all that's involved in communication, right? Just being able to produce the message doesn't necessarily mean that you can do all of the things that you want to do with your communication, because communication involves other people, and other people always make things more complicated. You might also have different situations depending on the setting or depending on the topic that you're talking about, or the context. So you may be able to type a message perfectly well, but maybe you're not able to effectively ask a question in certain situations, like maybe you're meeting with a lawyer or financial advisor. Can you get your questions answered? What about talking with a small group of people? If the conversation's going around and around, are you able to get a word in and say what you need to say? What about going shopping or other activities out in the community? Are you able to communicate and do the things that you need to do to talk with the store clerk or to ask a question about something? Same thing with visiting your doctor. Are you able to adequately answer the doctor's questions and ask your own questions? Are you able to use the telephone? Even things like talking to your pets, that's a different kind of communication situation. So communicative participation asks, how well are you actually able to participate in these daily activities that are important to you using the methods that you have available? So in this survey, I asked, how difficult is it for you to do a variety of communication tasks? So these involve things like, how difficult is it for you to talk with people you know, to talk with people you don't know, to communicate during an emergency? There were 10 different situations that I asked about. And depending on how much time we have, I'll go through a couple of those. For people who reported that they used some AAC methods, I asked them to rate that both with all of your communication methods, how difficult it is for you to do that? And then how difficult is it for you to do that if you can only use your natural speech or body movements like eye movements or gestures? And people could answer with not at all, I had no difficulty, a little difficulty, it's quite a bit difficult, or it's very difficult. And I'll just, we don't have too much time, so I'll just show a couple of the results, but here's for the question, how difficult is it for you to talk with people you know? This bar over here on the left shows the results for people who reported that they don't use any AAC, so they're using only their natural speech and maybe some gestures, other things that you can do with body movements. You can see most people find it not at all difficult or only a little difficult to talk with people they know. That's the yellow and kind of lighter orange up here. If we look to just to the right, this is people who reported that they do use some AAC. And the first bar kind of in the middle shows how well they feel like they can participate when they're using only their natural speech and body movements. So that's unaided communication only. You can see there's a lot more folks down at the red end of the scale who said it was very difficult. Over on the right, that's how it changes if they have access to all of their communication methods. So you're not stuck just using your speech and gestures. You also have your communication board available, or you have your tablet with your app, or you have your eye gaze device available. You can see that communicative participation is a lot better when they have all those methods available. And these kind of curves in the middle show how it changes. So the people who are in the red section using only unaided communication, most of them do improve. They move up into the yellow or orange sections if they have all of their methods available. So some of the other situations, kind of similar results for having a conversation that needs to be quick. A lot of people found that difficult with only unaided communication, but did see some improvement using AAC. Same for talking with people you do not know and communicating in small groups. Sorry, I'm skipping through these quickly, but I can make more of this information available to folks who are interested. And as Melanie said, the slides will be available. Having a long conversation with someone you know. So you're still talking with someone you know, but the context has changed. Having a long conversation, that's where things like fatigue come in. Again, a lot of people find that difficult with unaided communication only. It does get better, but there are still quite a few folks who still find it very difficult, even with all methods at their disposal. Getting your turn in a fast moving conversation. This is an interesting one because you can see there's not much change for the people who use aided communication between using only their speech and when they have all of their methods. You know, about 75% of people said it was very difficult using only their speech, and about 61% said it was still very difficult even if they had all their communication methods at their disposal. So that kind of shows one of the weaknesses of AAC. It is usually kind of time consuming to put in a message and have it spoken. So it can be difficult to get your turn and to kind of keep up with a conversation that's moving along quickly and may kind of move on without you before you're really ready to have your message ready to go. Having a conversation when you are upset is also something that people found very difficult, both with and without all of their communication methods. Communicate during an emergency. People did find AAC to be helpful here. You see a pretty big change when people have all of their methods. Having a short phone call. This was something that was relatively easy compared to some of the other situations, even for folks not using all of their communication methods. So if someone knows you well, they may be able to understand your speech pretty well over the phone, or you may have kind of a system worked out where you do a lot of yes/no questions over the phone. But it does still seem to be very helpful to have access to AAC in that situation. And same thing for video calls. Here we can see only about 5% of people still found video calls very difficult when they had access to all of their communication methods. So AAC seems to be quite helpful in this situation. So I also looked at overall communicative participation scores. So adding up the scores for each of those individual situations to kind of get a total picture of how well people rated their communicative participation. Here, the yellow dots are people using only unaided communication. So again, that's only your natural speech and things like gestures and other body movements that you can do. The columns here are the different ratings on that speech scale. So over on the left is people who had no change to their speech at all. The second one is a little bit of change. The third is I'm starting to have trouble being understood. I have to repeat myself sometimes. The fourth column, second from the right, is I'm combining speech with other communication methods. And the last column on the right is I'm unable to speak. I'm only using AAC. So you can see the yellow dots where you're using only unaided communication. There's a pretty steady decline in people's ratings of their communicative participation as their speech changes. What's interesting is these blue dots where people have access to all of their AAC methods. We kind of see a little ski jump effect where it continues to go down, although not quite as much when you get to the point of needing to use some AAC. And then it actually appears to improve at the point where people are using AAC all of the time when they're not able to speak anymore. So that it's that would be an interesting area for future research to kind of delve into why that happens, why there's that kind of ski jump and it improves. It may have to do with, you've spent more time using your AAC at that point, you're more used to it, you're more skilled at it, and it becomes easier to communicate using those other methods. It may have to do with changing expectations, either from yourself or from the people that you communicate with. Things kind of in the situation that makes it easier to communicate. But the overall picture that we're getting from this research, and I'm kind of just starting data analysis, I'll be publishing on this probably sometime next year. But the overall picture seems to be that AAC is helpful. It does help people communicate better in a variety of different situations. This is all self-ratings, so people's own feelings about how well they participate. So it was nice to see that AAC makes a difference, and it appears that the longer you use it, the better effect it has. All right, so that's kind of a preview of my dissertation research. I will have more information available for any pals who are interested in that. Feel free to contact me. I can get you more information about that as well. And that is it for our formal presentation. And I know both Melanie and I are happy to answer any questions that you may have.
Great, thanks, Bets. Can you unshare your screen? Thanks. Great. Thank you, Bets and Melanie, for the excellent presentation and an overview of BCI, as well as Bets, your research about experiences with AAC. We have a number of questions come in through the Q&A box, and people can continue to submit there, but I want to summarize a few of them. First of all, thank you. One question was, how do people contact you to participate in research? So you shared that, and we absolutely can share your contact information with anyone who's interested in participating in that. But the next question, a few questions came in that I'm going to sort of synthesize together, is when will BCI become available to the majority of people outside of research? What's the timeline for translational research to occur and become available and applied in the community?
Well, that is difficult to answer. I know that the VA has funded a few BCI systems for people with ALS. I'm not sure if the Portland VA has yet, but some of the other VA systems around the country have started to do that. I've not yet heard of any other insurance providers who have funded it. I know that there are some pals who've contacted us for information about how they can access it with private resources. There are a couple of companies that are selling commercial BCI systems. But again, so obstacles there, insurance doesn't cover it yet. It is a pretty difficult system for caregivers to set up and use. It takes a lot of, putting on the cap, adjusting the signals, making sure that everything's working right. What happens if it breaks down? There's a lot of components. It's very expensive. So as far as a timeline for when it will be widely available, I don't think we have enough information to answer that yet, unfortunately. Melanie, do you want to add anything? I wish I had a better answer for you.
Well, this is sort of a follow-on question. Knowing that there are sort of research technologies that sometimes are being made available to people, someone asked a question, is there any BCI available that is truly reliable for yes/no responses?
Truly reliable for yes/no responses. There is a BCI that was designed and is being marketed specifically for yes/no communication. We have tried it with a few folks in our lab and found it to be pretty hit or miss, unfortunately. Seems to work well for some folks and not so well for other folks, with no clear reason for why it works for some and not for others. So I would say definitely outside of a research context, I would say the answer to that question is no. There isn't anything that's widely available that is reliable for yes/no, okay, unfortunately.
Thanks. It's good to know. At least we understand what's out there. When we talk about research, it's, I always remind everyone we're in the learning phase of understanding how these technologies can work. Similarly, I've got a couple questions here about sort of the conditions for when BCI would be appropriate for people. One is if someone had FTD, frontal temporal dementia, would they be able to respond using the same alphabetic response?
So that's a great question. We did look at whether someone could use BCI if they had dementia, and that was with mild Alzheimer's disease. And the answer for mild Alzheimer's disease was they could. You know, in general, individuals with frontotemporal dementia have a hard time learning communication devices. So not only brain-computer interfaces, but all of the different steps that go into putting together use of a new technology for speech and communication, you're going to have those same problems with frontotemporal dementia and BCI.
Okay, great. A similar question. What's sort of the time frame process it takes if you're using BCI to compose like common phrases or messages? Is it a slow input process? You know, like people are wondering, is it fatiguing? Does it take a long time to compose like a sentence or message?
I would say in terms of the rate of communication, depending on the type of BCI, it's pretty similar to, at least for non-invasive BCI. They're having faster results with the implantable BCI because you get a better, stronger signal because you don't have to go through layers of hair and skin and bone to get the brain signals. So again, tune in for Dr. Shah's presentation on Wednesday to hear more about that. But with the non-invasive systems, I would say it's pretty similar to the typing rate you would get with using an eye tracking system, or sometimes a switch scanning system where the computer kind of scans through options and you're hitting a button to select the option that you want. In this case, the brain, you hit the button with your brain essentially instead of with a body part. So yes, it is a relatively slow communication method, at least for the non-invasive systems, pretty comparable to the other AA systems that are already available.
Yeah, I think you sort of accidentally answered the next question, which I want to make sure to mention that someone typed in, which is, what are the advantages or disadvantages of these methods compared to eye gaze devices? So,
yeah. Well, I would say if you can use an eye gaze device, probably BCI, at least non-invasive BCI, wouldn't offer too much of an advantage at this point. I didn't use, you'd asked about fatigue in the previous question. I don't think I addressed that. That seems to be a matter of personal preference. We did a study with a couple of people with ALS where they used both brain-computer interface system and an eye gaze system that basically used the same user interface. So what they saw on the screen was pretty similar, but they were using either eye movements or brain signals. One of the people really could not control his eye movements well enough to do anything at all with eye gaze, but he was able to type some words with the BCI. The other user, he could use his eye gaze fairly well, but he made a lot of errors that he would then have to correct. For him, the BCI was slower, but it was more accurate. And so he said he actually preferred that. That was his personal preference. Like, I would rather just be 99 to 100% accurate and have it take more time than be 70% accurate and have to use backspace and correct a whole bunch of errors.
Well, another question that sort of melds into this that someone typed in is around literacy and how's BCI work? Have you had experience with people who have like poor spelling skills or literacy issues? What is our approach for BCI that works for those people?
So on our systems, you saw that we have a language model working. So when we were spelling apple, did you see how quickly that L showed up? Mm-hmm. Because the machine knew there aren't very many words with APPL. So if you have literacy challenges, the language model will take over and sometimes give you words you don't want. Not all BCI systems have a language model embedded. So then you're going to spell like you would spell with any other communication device. And for some individuals, it's okay to have incorrect spelling as long as they get their message across. So that's another personal preference. I also would like to say before we leave, I've been in the AAC field long enough to have watched the research on eye gaze happen. So there was no eye gaze device before. And now that's almost a standard for us. So what I'd like to say is there is hope for BCI. It will happen, but we want to make sure when it does happen that it's reliable, consistent, and safe for everybody.
I appreciate that perspective, Melanie, and you've got the history to have seen some of these technologies evolve. And for our audience who doesn't know, Melanie goes back to some of the very beginnings of AAC, and this particularly was beneficial in making sure that AAC could be funded through insurance and Medicare. So a lot of her advocacy work made that possible. But we're coming close to the end of our time. I did have one more question I wanted to put forward, and it's about sort of feeds back into both Melanie and you, Bets, your perspective on who BCI is appropriate for. This person asks like a basic question. So by the time a person with ALS needs BCI, what is their typical health status? Is this for people who maybe are more locked in or have more disability? Who's this going to be appropriate for?
Yeah, that's a really great question. The answer is it will be most useful for people who are getting toward the stage of being locked in. At this point, because of the expense, the setup difficulty, just kind of the overall complicatedness of it. If you can use another method, it's probably best to stick with another method. That being said, there's some evidence that the longer in the progression that you wait to learn a BCI, the harder it is to learn. So there hasn't been a lot of study on this, but there was at least one study that showed that they looked at people with ALS specifically. If you started trying to learn the system kind of earlier on, when you were still able to do lots of other communication methods, they maintained that skill. But sometimes, not always, but sometimes folks who are trying to learn BCI when they're already locked in or at the point of becoming locked in, they may have difficulty learning to use it.
Great.
I would also like to add that all of us use many different communication methods, right? So now we're using Zoom, we write, we text, we use email. So consider for those of you who are experiencing challenges, make sure you have a full array of communication methods, and BCI could start to be within that full array.
Great. That's a great sort of closing point for us today. I want to thank Melanie and Bets for both their time preparing the presentation and sharing with our community today, but also for the hard work that we see you putting in every day to advance this technology to benefit people with ALS and people with disabilities. We appreciate all that you do and the efforts that you are leaning into to make a world a better place for people living with ALS. So thank you guys so much. Well, so please join us again tomorrow, Tuesday at noon for our next presentation, which will be with Dr. Nick Olney from the Providence ALS Center discussing clinical trials and some of the potential treatments that are being developed to slow or stop ALS. So thank you all for being with us today, and we really appreciate you carving your time. Thank you so much.
Thanks for coming, everybody, and thanks for the great questions. Thanks, Lance, for hosting us.
Okay.